everybody. So this is going to be the second part of the first set of lectures, and this is going to cover your subjective and objective data. So essentially, this is your history and physical exam. I do have the auscultation part on a separate lecture, and I will post that separately because I want to make sure that you have a good understanding of that because it's obviously critical to your practice, and make sure that you have that down pat. So first we're going to take a look at subjective data. This is, like I said, where we're looking at the history and kind of inquiring about certain symptoms and asking your patient questions. So in general, even if you're doing like a regular, general intake exam on your patient where you're kind of looking at all of their subjective data and kind of going through different systems, you always want to ask about a cough with your patient, and we'll kind of take a look at these separately. Any shortness of breath in your patient, any history of respiratory infections, either recently or within the past year or two, any smoking history, and we'll kind of look at these separately. Environmental exposures, and then self-care behaviors too. So when we're looking at a cough, or you have a patient that's presenting with a cough, you're obviously going to ask, do you have a cough, and when did it start? So remember that old CART acronym that I gave you, so onset, location, duration, aggravating, alleviating. So that's kind of how you have to take an approach with these, with a symptom essentially. So a symptom is cough. You want to ask them how long have they had it? When did it start? A lot of times I ask my patients too, how did it start? Was it a dry cough when it started? Did it turn over into a productive cough? Are you coughing more at night? Is it during the day? Kind of differentiating when these symptoms are occurring. Are you coughing up phlegm or sputum? Because that's a big thing too. Is it a dry cough, or is it a productive cough? And how much? Is it worse in the morning? What color is it? And we'll kind of look at the color of sputum as well as we move through. Are you coughing up any blood, or is it blood tinged? Does it look like streaks, or is it a lot of blood? Or is it dark blood? Does your sputum have any odor? Like, do you have any odor with it? Because that can indicate infection at times. So sometimes we'll ask that as well. In describing the cough, this is kind of important too because it kind of helps differentiate between what's kind of going on. For instance, like in a child, if you have that barking cough, a lot of times it's associated with croup. If you have a congested phlegmy cough or a productive cough, a lot of times that'll happen with an upper respiratory infection. If they have a dry cough that they get worse with running or activity, it kind of tends us to believe that it might be more of asthma related, and you have to put all these symptoms together to figure out what's going on. If they don't have a fever and they have this cough with exercise, it's more likely asthma. If they have a cough that has a lot of mucus and they have a fever, then you're worried about an infection. So it's putting all of that information together and kind of looking at it. Coughs can also be related to, believe it or not, gastric reflux. A lot of times you'll have patients that will present with a chronic cough, and it's actually from underlying reflux disease where they have acid coming up. And a lot of times it happens at night, and they don't even realize it, and then they develop this chronic cough. So we worry about aspiration pneumonia. There's a lot of things. So, cough sounds rather benign, but there's a lot of other areas that you got to kind of think about. Like I mentioned, is it worse with activity? Like if you have asthma, a lot of times it'll be worse with if running, or if they go out in the cold, it'll get worse. Position, so if they're lying, is it worse when they're lying down? Because a lot of times you get drainage when you lie down. The other thing too is when you're lying, a lot of times they don't get good chest expansion. So you'll see a lot of COPD patients sitting up because they can open their airways better essentially. Do they have fever or congestion going on with it? Because then you're worried about more of an infectious process. Do they have shortness of breath with talking? Anxiety. Anxiety can cause, that shortness of breath, or it's vice versa. The shortness of breath and cough can cause anxiety. So it can kind of go both ways. Does activity make it better or worse? What have you tried? So you always ask your patient, what have you tried at home? Have you tried any over-the-counter medicines? Because you want to know what they've taken too. That's the other thing. Do they use any prescription medicines? Have they tried an antibiotic that their doctor prescribed? Are they using a decongestant, vaporizers? Have they tried rest or position changes? That way it kind of helps you clue in as to what's going on and what the cough is actually from. Do you have any chest pain with the cough or ear pain? The ear pain thing, that's kind of a little bit separate, but the ear pain would be if they had like an upper respiratory infection with an ear infection. Chest pain can kind of be associated with bronchitis. If they have pain like in the upper front part when they cough, a lot of times with bronchitis, they'll get that from the irritation. And a lot of times too, I always ask the patient about their perspective and what do they think it is, or do you know anybody that's been sick in your house? Sometimes they can link it back to something that they've done or someone they've been around, etc. When we look at sputum or inquire about a sputum, you can't always base, um, you know, a decision off of sputum because sputum it can vary, and it's not always an indicator of pathology, and it's not always an indicator that there's an infection going on. But these are some of the ones that they're highly linked, like frothy white sputum. They look kind of more of like a bubbly white, frothy type sputum. And we see this a lot with pulmonary edema. So if they have a lot of fluid on the lungs, they have all this frothy sputum. Sometimes you'll see it like on the side of their mouth. It may be a tiny bit blood stained just from the irritation kind of going on there. If you're seeing frank bloody sputum, that's when we say frank, that means that it's bright red. That would be not always, like I said, if they have chest pain and the shortness of breath and anxiety. That's another thing that anxiety will go along with as a PE. If you see that bright red blood and they're having all these other symptoms, that's something that we definitely look at for pulmonary embolism. And pulmonary embolism, they always end up, it comes from a DVT. So it usually ends up, what happens is if they have a DVT and it goes up to their lungs, through the heart into the lungs, and it lodges into the lungs. We'll look at that when we look at abnormals. Blood-stained sputum, where they just have tiny bits of streaks of blood, where they, if they were to spit and they notice that there's a little bit of blood in it. This is usually if they have an underlying infection like pneumonia or an abscess. Believe it or not, people can actually get abscesses in their lung. Or aspiration of stomach contents, like I said, because it's very irritating to the airways. We always worry about aspiration pneumonia because a lot of times your patients are laying down. And if they have any compromised, breathing or level of consciousness changes, we always worry about aspiration pneumonia. Green or purulent sputum, this is when it's more of a signal of infection. So when you see green or purulent sputum or like a dark greenish brown, and they're having symptoms of an infection, obviously we're going to really look into that and make sure that they don't have pneumonia. Nowadays, with everything in diagnostic testing, we kind of jump the gun, and a lot of times we'll just get chest x-rays. So a lot of times, in coordination with their symptoms, we look at diagnostic testing to kind of look at this as well. And, we look at their CBC, which is their blood counts, a lot of other things to kind of look at the patient as well. Yellow-green sputum. If it's yellowish green, I guess if it's more green, then you'd be a little bit more concerned. But yellow is actually not that abnormal. You'll see this a lot with people that have chronic lung disease. If they have chronic bronchitis, which is actually a form of COPD, they tend to have a chronic cough all the time. And most of the time, a lot of them have a productive cough where they kind of cough up yellow stuff. So it's not always an indicator of infection. You have to look at your patient and what their history is to kind of put that together. Black sputum, a lot of times it'll be like dark brown, and that'll be in smokers. Old blood, that can happen with TB or lung cancer. So a lot of times if you look at it, the difference of, an acute issue like a PE, it's more bright red blood versus lung cancer or TB. It's going to be that old blood. It's going to be more of a brownish color. So these are just some indicators to kind of look at with sputum, essentially. Now, in terms of shortness of breath, if your patient is presenting with this, you always want to ask about what's bringing it on. Is it worse with activity? Is it worse when they lay down? Is it all the time? And how severe it is. And a lot of times you can kind of gauge how severe it is just by looking at them, number one, and if they can even walk across the room, or how are they, doing with their activities of daily living? Can they walk from, their car into the house, and, just inquiring about stuff like that. And how long does the shortness of breath last? Is it affected by their position, if they're laying down or sitting upright? You'll see a lot of patients with chronic lung disease that actually will sit or sleep in a recliner because if they lay down, it gets exacerbated. So these are just some key factors to kind of look at. Is it occurring at a certain time in the day? Are they getting it more at night? Because a lot of times, like I said, laying down, they get worse. Another thing, too, which I'll talk about in a few slides, is with CHF. Obviously, a lot of times they have shortness of breath, and they'll have symptoms at night. So we'll have dyspnea, which is, that's what we basically call shortness of breath, or difficulty breathing would be called dyspnea. And we'll talk about that later. But Are they having any night sweats? Night sweats, we always are concerned with any underlying carcinoma. Do they have changes in their CBCs with their counts? So you kind of got to put all that together. Do they have a cough with the shortness of breath? Is it an acute issue? Did this just occur? Do they have chest pain with shortness of breath? Do they have any indicators of cyanosis, like blue color around the lips or nails? So if they had clubbing of the fingers, then we're worried about more of a long-term, cyanosis essentially. If it's, if they have chest pain with it and they're short of breath and it's an acute issue, then, we worry about, either an infection or even PE. So you got to kind of put all of it together. Do they hear a wheezing sound? That's another thing. A lot of times patients with asthma or even emphysema and COPD, they can audibly hear wheezing within their own chest when it's, when it gets bad. Are these episodes related to anything such as food, like an allergy or pollen or dust, animals, season, or emotion? These are all triggers for like an asthma. And sometimes people with COPD, these will kind of exacerbate it as well, but this is mainly allergies that we're looking at with this in asthma. What do you do when you have a hard time breathing? Do you change your position? Do you use pursed lip breathing, which we'll look at in a few? Do you use oxygen at home? Are you on inhalers? Are you on medications? So you got to inquire about all of these factors. What inhaler do they use? How often are they using it? Are they using it properly? I kind of talked about that in pharmacology. You'll find a lot of times that people don't use their inhalers properly. So you really have to inquire about all of these factors. Is it affecting your work or your home activities, like I mentioned before? Is it getting better or staying worse or staying the same? This is a question I always ask my patients, even if they're sick. How do you feel today? Is it better than yesterday or is it getting worse? You kind of want to gauge their symptoms and see where they're at, where they're at essentially with it, because it can kind of help you tell a little bit more too about what's going on. In terms of chest pain with breathing, basically you're going to ask them, do they have any chest pain with breathing? And then you can have them point to the exact location and say, can you please, let me know, where do you feel this pain? When did the pain start? Is it constant or does it come and go? Is it worse with activity? Do they notice it more if they're walking around, or do they notice it more when they take a deep breath, or do they notice it when they're sitting? And you want to have them describe the pain. Is it burning, stabbing, or like a sharp pain? Sometimes, like I said, with pleurisy, they'll have like more of that sharp pain there. If they have pain in their chest, like their upper chest, sometimes even gastritis or gastroesophageal reflux can cause burning like up in the, it'd be high up if they had that. But, it's all in the same area, so you really have to inquire about what's going on. Do they have a recent respiratory infection, or have they been around somebody sick? Are they coughing with this chest pain? Or do they have trauma? If they had some sort of blunt trauma, you want to inquire about that kind of trauma. Do they have a fever with this? And, just looking at your patient, do they have equal chest expansion and stuff like that? And we'll talk about that as we go into the exam. What have you done at home to treat it? Have you tried medication or heat application? Sometimes chest pain in certain areas, you have to always rule out other causes and more, obviously more detrimental causes before you can say that it's something related to musculoskeletal or something like that. So you always have to make sure that, that we look at cardiac etiologies and respiratory etiologies as well. You always want to inquire about history of respiratory infections. Do they have a history of TB? I mean, you have to really inquire about this. Have they had problems with breathing in the past, or do they have any underlying lung diseases that they know of? There's chronic bronchitis and emphysema, which is COPD. There's bronchitis that you can get if you're sick, but there's also chronic bronchitis with COPD. Do they have a history of asthma? Patients with asthma, they're just more susceptible to getting infections, and when they get infections in the respiratory tract, it's harder for them to overcome, or they have an exacerbation of their asthma and emphysema. So a lot of times, a minor upper respiratory infection can become detrimental to a patient that has emphysema or asthma. Have they had pneumonia in the past? Some people you'll find that are just more prone to developing respiratory infections than others. And a lot of it's related to their past history as well. Have they had a cold recently? Because a lot of times, sometimes it'll start as a virus and then it turns up into an infection. Do they have any family history of allergies? Because like I said, allergies go hand in hand with asthma. And a lot of this just makes them more susceptible. TB, like I mentioned, have they ever had that in the past, or any family history with that in the past, or exposure essentially, or travel? You got to think about all these factors when you're looking into this. Environmental exposure, what do they do for a living? Where do they work? Are they at a factory or a chemical plant, a coal mine, farming, outdoors in heavy traffic? A lot of times, it's going to cause them issues, obviously, with their pulmonary status. So you got to look at other factors too, outside of just the patient's health and what they're exposed to as well. Are they wearing anything to protect their lungs? If they're working with certain chemicals, or with that in an environment that they need to wear a mask. Just inquiring more about this exposure as well. Have you had periodic examinations, a PFT? So if a patient has like underlying asthma, or even like chronic lung disease or COPD, a lot of times in the outpatient setting, we'll do pulmonary function tests. So this looks at how well they're basically breathing. How are they? How well are their airways expiring essentially and inspiring? But we look at this a lot with asthma and COPD, and it kind of gauges like where they're at, or if they need a change in treatment essentially. In terms of x-ray examinations, we typically do not recommend, yearly x-rays or anything like that. If a patient does have a very significant history of smoking, that is something that we will look at with a patient, doing x-rays. But we don't typically do them just because, essentially, because you're exposing your patient to radiation when you do that. So we try not to do that unless there's an indication there. Are there any symptoms that the patient knows that they've had a history of, with their breathing problems? Is there anything that links there that the patient can think of? So really just discussing it with your patient is an important area to think about. Other subjective data that we always inquire about is smoking history, and seeing if they smoke cigars, cigarettes. And e-cigarettes is another one too, and there's like a lot of new data out on that too, because I think people think that it's safer than it really is. But when we inquire about smoking, we do calculate what we call pack years. Pack years is basically the number of packs smoked per day times the number of years. So for example, if the patient said that they smoked 2 packs a day for 15 years, what you're doing, we calculate it as pack years essentially. So 2 times 15 would be 30 pack years. So even though they only smoked 15 years, we calculate it as 30 pack years because they were smoking 2 packs a day. So that's how you calculate pack years, because sometimes when you're documenting, that's how you write it in there. Patient smokes 30 pack years or something like that. And you want to write, it's cigarettes or what they smoke. And nowadays, too, you have to inquire about, marijuana use and stuff like that, too, because it's pretty prominent. And they have the same risk factors that patients would have if they smoke cigarettes. So that's another area you really have to inquire about. And then you always want to inquire about, have they ever tried to quit? What's helped in the past? What did not work? Are they ready to quit? That's a huge thing. If they're not really ready to quit, you really got to, you have to try to talk to them about it and make sure that they have available options, but they have to be willing to quit. So it's something that you really got to think about as well. And another factor too is inquiring about anybody that smokes in the home, because obviously secondhand smoke is just as bad. And you'll see patients that unfortunately don't smoke but have a partner that smokes, and they end up with COPD from it. So it's another huge thing with asthma. If they're smoking in the home with a child that has asthma, or even an adult with asthma, even the scent of smoke on patients' clothes can actually trigger asthma issues in patients as well. So it's important to always inquire about this with your patient, and always offering, if they are willing to quit, and receptive to you discussing with them about smoking cessation, essentially. In terms of patient-centered care and basically health promotion, looking at self-care behaviors, did they have a chest x-ray ever done in the past? Just asking them about this. If they've been exposed to TB, have they had a TB skin test? Not everybody gets TB skin tests. A lot of times it's healthcare providers like us that get the TB testing. But looking at, their history there and asking if they've had any of this done. In terms of health promotion, there is the pneumonia vaccine and obviously your influenza vaccination. So these are 2 areas of health promotion that you would think about with pulmonary. The pneumonia vaccine is typically indicated for those with any chronic lung disease. So like your asthma or your COPD patients should get your pneumococcal vaccination. As people get older, we do still recommend the pneumococcal vaccine, typically ages, I think it's 60 and up. And influenza vaccination, we obviously recommend yearly for these patients. So the higher the risk of the patient, the more important it is to talk to to talk to your patient about getting their vaccinations, because they're more apt to getting infections, and obviously it becomes more detrimental to them when they have pneumonia or influenza. In terms of the aging adult, like I said, they can have more issues with pulmonary conditions because of the changes in their, the structure of their body and at the micro level. Do they have fatigue? Fatigue can be their only symptom. Sometimes they don't even notice that they have shortness of breath because they become used to it. Sometimes they just say, yeah, I have a difficulty, doing this activity, and they really don't pinpoint why, but sometimes you'll find out it's because they get tired or they have shortness of breath with it. So you can inquire about their physical activity. Do you walk? Are you using an aid? Do you use a cane? Are you able to, go up your stairs in your home without getting short of breath? It's just kind of inquiring about how they're getting around. For those with a history of COPD or lung cancer or TB, how do you feel each day? Are you getting through your activities? Weight changes, that's a huge thing. And a lot of times, we fail to kind of even look at this, but a lot of times any chronic disease like this, they can have, weight changes in previous months. And it's typically weight loss that they usually have with this, but it could be the opposite. It could be weight gain because they're more sedentary. So that's just something to think about. And you obviously are going to inquire about how much weight gain or weight loss. How is it affecting your energy level? Do you feel like you get tired more easily? Does it affect you at home or at work? And a lot of times it does. A lot of these chronic pulmonary conditions make a huge impact on the patient's life. So we really got to make sure that we get them functioning good. And there's different interventions that we can do, and making sure that they're doing their medications properly and their inhalers properly, and even monitoring their symptoms so that they don't have exacerbations. And this is stuff that we'll look at with more of the abnormals, but there's even like pulmonary rehab. So a lot of times patients that have, pulmonary conditions, we can even try something like that. And it's just making your patients aware that there is help and that we can try different interventions to make them feel better, essentially. Do they have chest pain with breathing? And do you have any chest pain after coughing or after a fall? Obviously, you always worry about, other issues going on there as well. The next lecture, I'm going to split this up into another one. So we're going to go through the objective data or your physical exam for the respiratory assessment in a separate lecture. So proceed with that one next. And if you have any questions, obviously let me know. Thanks.